Current therapy, adequate treatment of tuberculosis disease is essential and serves several goals: curing the patient, preventing relapse, reactivation, preventing antibiotic resistance, prevention of the transmission of the MTB, NVALT 2014. The treatment regimen depends on the resistant state of MTB. More resistant variants need different drug choices and longer treatment duration. The standard treatment of drug-susceptible tuberculosis consists of two phases: the intensive phase, 2 months, and the continuous phase, 4 months. The principle of the intensive phase is to induce a strong reduction in bacterial load, after which the continuous phase should facilitate sterilization of the infection 1. During the intensive phase, a combination of 4 different antibiotics is administered: isoniazid, pyrazinamide, ethambutol, and rifampicin. In the continuous phase, only isoniazid and rifampicin are normally given. It is important to state that such a lengthy treatment is essential to eradicate the whole infection. As mentioned in the previous post about MTB and the immune system, MTB is extremely good in surviving within macrophages and granulomas, which leads to a dormant state of the bacterium that is less susceptible to antibiotics. To target those latent bacteria, an intensive phase alone is not sufficient to kill them. Therefore, a continuation phase follows to ensure eradication of the infection. The tuberculosis multidrug therapy has side effects. Fatigue, GI tract symptoms, and hepatotoxicity are the most common ones. There are also drug-specific side effects, like GI tract consequences by pyrazinamide and neuritis optica by ethambutol 3,4. Rifampicin is a big inducer of CYP450 enzymes in the liver, especially the CYP3A4. This leads to an increased metabolization of certain drugs, reducing their efficacy. Examples are oral contraceptives, antiretroviral drugs, warfarin, anticoagulant, and immunosuppressants. So in case of HIV-TB co-infection, it is important to monitor CD4 plus T-cell counts because of the increased metabolization of antiretroviral drugs. Furthermore, liver function needs to be monitored during therapy because of the hepatotoxic effects of isoniazid, rifampicin, and pyrazinamide. If there is an induction for hepatotoxicity, then the tuberculostatics need to be stopped. It may be necessary to switch to non-hepatotoxic drugs. However, it is important to take into account that administering only one drug is not an option because of the risk to resistance development. Problems with current therapies. Bacterial resistance is a global health problem, and it also plays a significant role in tuberculosis disease. According to the WHO, World Health Organization, drug-resistant TB costs annually about 230,000 deaths, leading to a big public health impact. Over time, MTB has evolved to more resistant forms. Multi-drug-resistant TB, MDR, is resistant to multiple drugs, whereas extensively drug-resistant TB, XDR, is resistant to the most drugs, including second-line medicines, which are the strongest antibiotics available. More detailed information about TB resistance and its impact on public health is available in the next post. Monoresistance to rifampicin occurs rarely. Rifampicin inhibits the RNA polymerase of the bacterium. To develop resistance, a mutation in the RPOB gene, which encodes the beta subunit of RNA polymerase, is needed. However, mutations in this part of the genome often make the MTB unable to survive. So a specific mutation in this gene that can provide rifampicin resistance and not affect the bacterium's survival is needed. However, if those rare mutations occur, they could have disastrous impact since rifampicin is the keystone in the continuous phase of the treatment. XDR-TB is resistant to fluoroquinolones and for at least one of the antibiotics from the injectable second-line drugs. This is a huge problem since injectable second-line antibiotics are the most potent drugs against resistant forms of tuberculosis. So MDR and XDR need a complex, intensive, and an exceedingly long treating process. The question is whether in the future antibiotics will remain sufficient. New therapeutic interventions may be necessary. More about this in the Innovative Therapy post.